have to fill out this survey or just us?
I think everyone should have to experience.
Yeah, you guys should, you guys should have to go.
Yeah.
Yeah, but it's titled climate, it's nothing about the climate.
No, it's can't like
It's not
the,
about the weather.
No.
It's not.
That's what I thought it was.
That's what all of us perceived. And then I got these questions.
You're like,
I
what?
I was expecting how would you enjoy the weather?
Yeah. How has your experience been?
I was ready for this.
Are you married to multiple partners?
It's like the feeling that you get.
Just answer them. I looked at that survey, the results.
I'm
from
just
last
saying.
year.
Yeah.
There are some questions on there that are, you don't have to answer them.
Yeah, you gotta make a block. You gotta pick one of them.
unsure.
That's what I did.
I think probably it's not applicable.
It's a little awkward.
Okay, so review systems for cardiac chest pain. We've talked about chest pain, right? And pulm, you guys know what to ask. Angina, you know what angina is? Okay. Hypertension. Diaphoresis, you know what that word is now. Palpitations, you know what that is now. Dyspnea, dyspnea on exertion. T&D, orthopnea, edema. Why do you ask about rheumatic fever? Cause of murmurs, right? History of heart murmurs. It's always good to know if they have a heart murmur before you stick your stethoscope on there. So some people have been diagnosed with it. High cholesterol problems, and last EKG. Why do you have to have last EKG? Or no,
That also tells you if they're keeping
gotta
up,
have their old to look at their new.
it also
And
tells you if they're keeping up with their health, right?
it's exactly for health maintenance. You know, it's not so important for a 20-year-old, but for a 55-year-old, we missed the mark. For a 65-year-old, we haven't kept up with our health maintenance. It's a great point. And we can listen to music if you want. Play in the background. You know, the other thing is you should always have a baseline. So, yeah, it's nice to have the old one, but before we have to have an old one, let's just get the baseline. Get a baseline on these people. Okay? So we don't percuss the heart. So remember how it was, inspect, percuss, palpate, all that. We don't percuss, there's no benefit to it. It's too hard to percuss out the borders of the heart because of the rib cage and all that kind of stuff, so it's not been beneficial, so it's not in there. And then we do some special tests. So, what do we inspect on the heart? You look at the apical impulse. Okay, the apical impulse. Precordial impulse. There's a lot of different names for it. Okay, the apical impulse. It should be mid-clavicular line, 5th intercostal space. Left side. Remember the heart sits right here, right along here. About left, that's the normal spot. You may not see it on someone laying down, but you do most of your inspection when a person's laying down. Okay? This is the easiest to do. Left lateral decubitus, you know that's a position to help diagnose a lot of things. Okay? It's a very important position. What does it do to the heart? If I put you in the left lateral,
Takes pressure.
it brings your heart closer to the wall. Okay? You can hear the heart better. It accentuates some murmurs. Sometimes I can't see it of someone laying down because what happens to the heart, it's farther back when you're laying down, so it doesn't mean anything. So if I can't see the apical impulse on an obese, someone with a thick chest, then you may have to sit them up to look at the apical impulse. The apical impulse is very important, okay, because it tells us about heart size. Okay, palpation. So terms you should use are the right second intercostal space. How do we find the right, or I mean the second intercostal space?
Sternum notch.
Ankle of Louis is a good way, okay? If you palpate the clavicle, the first one down is the first, and then the second is below that. Okay, so clavicle underneath is one, and then one down, one more down is the second. That's your second intercostal space. If you feel over, that's where the angle of Louis is. So if you don't want to be doing this on someone, yeah, right. You can just come from their clavicle. 1, 2. Right intercostal space, it's called parasternal because it's next to the sternum. Okay, you have the left second intercostal space, parasternal. You have either, it's the fourth or fifth left parasternal area, and then the fifth mid, okay, fifth mid clavicular space, but we call it the apex. So you always see it just referred to as the apex. We've tried to get away from aortic, pulmonic, tricuspid, mitral, but I want you to know those things because it tells us what? Where the sound goes to, right? Right? That's where we hear those. Does your aorta, really sit here? Or does your mitral really sit there? They don't. That's where the sound projects. Okay. Where do you hear your S1 the most? I would bet where your apical implant. You hear it right here. Your fifth. You hear it at the apex. S1 is for best at the apex. Because it's where the ventricle contracts. Okay, your S2, best heard at the left second intercostal space. All right. So when you palpate the PMI, point of maximal impulse, there's another term. Why am I doing this to you? Because you're going to see it all different ways. Okay? You're palpating for two things. The size of it and where it's at. Okay? The size of it and where it's at. So mid-clavicular line is not the nipple line. Okay, because nipples can be here, nipples can be here. I'm just saying. I don't mean it terrible. So don't always use that as a reference on a person. Look at your mid-clavicular, right? Okay? So palpate your clavicle, both ends of it, your mid-clavicular, and that's where your PMI should be. If it is past that, you need to start thinking you have heart failure or a big heart of some kind. Okay? You also should note the size of that apical impulse, because it should not be greater than 2 finger widths. If I have this big pulse over here, something's not right. Something's not right. Okay? So here are some LRs that I just want you guys to look at. So apical impulse located outside the MCL, mid-clavicular line. So it tells you that you have an enlarged heart. So someone's telling me these stories and I think they probably have a big heart. And I palpate that, I can use that LR to predict, right? Okay. Ejection fraction. You guys haven't had congestive heart failure yet, right? The lower the ejection fraction, the less that heart can pump out. It's not efficient. That's related to how bad their heart is. So a lower ejection fraction is a bad thing. Okay, atrial impulse increases the probability that the left ventricular end diastolic volume is increased. Okay. Atrial impulse that is 4 centimeters or greater, okay? Did I say that last one? Oh, right. Apical impulse that is large. No, I didn't. Okay. Apical impulse that is 4 centimeter or greater increases the probability that the patient has a dilated heart. Remember you learned that from Amy, a dilated cardiomyopathy. Apical impulse that is 4 centimeters or greater, left ventricular end diastolic volume is increased. That's why we measure those two things. Those tell us something. 2 words, a lift and a thrill. Okay? So when I palpate the heart in those different areas, I'm feeling for a lift. A normal lift, in reality, is the PMI. It's a lift. But if it's more than normal, a little thud against it, that's what we call a lift in that area. You shouldn't feel the heart in these other areas. So if I palpate, or there's a pulsation in these other areas, that's a lift. Okay? A thrill is a vibration, okay, which correlates with a murmur. So if I put my hand here and I feel a vibration, that's a thrill. I shouldn't feel that. And when a murmur gets bad enough, usually a 4 out of 6, that's when you can palpate it. This tells you, if you palpate a thrill, what is the murmur? Okay, so the systolic murmurs, the second or third right intercostal space, if I palpate that over here, it's aortic stenosis. Yeah, okay. So if I told you that, if I just said that, you could at least get close to what type of murmur it was. Okay? So auscultation. I have to get you a new one of these because I didn't even, the people that got these, it's not even photocopied right. It's not my best quality is using the photocopier. Everyone knows that. Okay, so you always auscultate the heart with a diaphragm and valve. Always. Why? Different sounds, high and low pitched, right? Murmurs come high and low pitched. So you got to use you may not even hear a certain murmur if you just use your diaphragm. So always use both, always use both. Same places that we just talked about when you palpate. Okay. Remember, you're listening not over the valve, you're listening to where the valve projects its sound. That's what you need to think. That's exactly what happens when you're listening. So it's not over the valve, it's where the valve projects. That's what that second picture is. So S1, right? S1 is the closure of the mitral valve. It's what you're hearing. It's the start of systole. Okay? Splitting of S1 is never normal. So if you ever read a question and there's a splitting of S1, you know that it's not going to be something normal in your answers. Okay? If you hear a split S1, that love part, there's something wrong. Either there's an S4 there or something, there's something not right. So make sure you know that. Okay? S2, closure of the aortic and the pulmonic, and usually it happens at the same time, except when we take a big deep breath, right? That's a physiological S2 split. So that's normal. What's not normal is our wide physiological split. So it's split all the time. I take a big deep breath and it splits even more. Okay? Or a wide fixed split. Or a paradoxal split. So when I exhale, it splits. And that's really classic for aortic stenosis given.
Does a splitting S2 sound the same as an S4
No. Here's how you tell the
or
difference.
S3?
It's an S3. With an S3, it's a low pitch. So if you're using your diaphragm, you probably won't even hear a lot of times an S4. So if you switch over to the bell, then you'll hear, so if you're listening with your diaphragm, you'll hear it, okay? If you switch over to your bell, you may not hear the S2 split anymore.
Okay.
So S3 and S4 are low pitch. That's why you always have to use your bell, because you want to pick up an S3, S4. Okay, S3, low pitch. I'm going to tell you this is a board question every time. What does S3 tell you? Okay? What?
Volume overload.
It's volume overload. Okay? S3 can also be very normal. Okay? It can be normal. Kids, because what's happening is, what creates this S3 sound is fluid running into the ventricle. So it's a lot of fluid whooshing into the ventricle. So fluid overload would do that, right? Right? Say yes.
Yes.
You're hearing me, like I'm actually speaking. Okay? Healthy hearts, kids have great hearts. So the fluid that's coming into the heart comes in fast. So they also can create that S3. That's what the S3 is. So that's why. So someone who has an S3 that's 30 and healthy is normal. Someone who's 30, who has pitting edema, who's short of breath, who has dyspnea, and all those types of things, that's not normal. Okay? Make sense? Okay. That's what you need to know. It can also happen in mitral regurg, which makes sense, the backflow. Okay, it's the sound rushing in to that ventricle. Okay, S4 is never normal. Never normal. It's low pitched, again, it's low pitched. It comes right before S1. And it's as those ventricles stiffen. So we see this a lot in the lecture that you had with Amy, right? So restrictive, right, or hypertrophic cardiomyopathy, or people with hypertensive. So those ventricles don't work very well. They're not big and floppy, but they're real tight. That's what causes an S wall. So you get real hypertrophic, thickened ventricles. Okay? I just found this, so this is another way, instead of the thing I gave you, that you can create a sound of a heart. So the ring finger, so S1 is middle, index finger is S2, so you can practice hearing in a heart that's low done, low done. And the creation of an S3 and an S4 is a lower sound, so if you hit your thumb, okay, or your ring finger, it's a lower versus, see how it's a lower pitch. So you can practice that at home, hearing that S1 is definitely higher. Just something to practice. It's hard. Hearing the heart is one of the hardest things to do. Okay, it's difficult. So you listen for different sounds, clicks. Okay, you listen for murmurs, the intensity of the pitch. I know that Shelley beats you guys up with this, with murmurs. I get it. I'm not going to go over the murmurs. I'm not. But it takes a lot of practice with the stethoscope to hear them, and that's why you have to use diaphragm and bell. Diaphragm and bell, diaphragm and bell. People don't do it, okay? But here's what you need to know. If you hear a murmur, you want to see if it gets better or worse with different maneuvers. I know that Shelley talked about this, but I want to put it in your head a little more, okay? Because this will help you get to the right answer on a test. And the right answer with a patient is you need to know where to send them, okay? So, if you're going to, you hear a murmur, and you want to know what kind of murmur this is. I want to see if it gets worse or better with certain maneuvers. So, if I have them take a big deep breath in, I increase their venous return, right? Okay? Right-sided murmurs increase. They are going to increase. What's going to happen to a left-sided murmur? It's not going to affect it. It's really just not going to affect it. What's going to happen to hypertrophic cardiomyopathy? Doesn't really affect it. Okay? So it didn't help me with two types of murmurs. They're two big deals. Expiration decreases the venous return. Okay? Left-sided murmurs increase. Okay? Hypertrophic cardiomyopathy doesn't really affect it. So inspiration, expiration really doesn't affect it too much. Squatting. Okay, so I'm going to have a person stand and squat and listen to them. Okay, what is that going to do to my heart?
Increases peripheral resistance. So you would expect it to increase?
Increased pressure.
It deals with preload.
Increases.
It increases preload. Okay? So, I have them squat. Okay? And you listen right when they squat. What happens with cardiomyopathy, hypertrophic cardiomyopathy, it decreases. And most other murmurs increase. Okay. When I go from squatting, okay, to standing, okay, I decrease preload. Because actually what happens is blood flow goes down. So it's the exact opposite. And actually how you have to do that to get a good response is you actually have to make them squat for about 30 seconds. And then have them stand and listen right when they stand. Okay? Valsalva. So you make them put their tongue up, hold, kind of hold, bear down, right? They need to bear down for 20 seconds. This decreases our venous return. Okay? And a murmur with hypertrophic cardiomyopathy, what happens? It increases. This test is huge for hypertrophic cardiomyopathy. This is the test. An LR of 14 is huge. So, increased venous return, there's a couple things you can do, right? You can squat, the squat stand test I'm talking about. But that's hard to do with the elderly. Another one you can do is just passive leg raise. We'll do that. Really understand this. Special maneuvers are huge. Okay? It's a big deal. Do you guys have the notes that you took with Laura? Let's do this calculation. Let's do the calculation with the Valsalva. Okay? So let me give you a scenario. I wrote it out. So you don't have to write anything yet. So a 17-year-old male basketball player in for had shortness of breath, episodic chest pains, palpitations last week while he was playing in a pickup game. He notices that he occasionally gets these episodes of dizziness, hasn't really thought about it because he's in shape, he works out 3 times a week, but really enjoys playing this game. But last week, it scared him enough to come into your office. Okay, so what's his chief complaint? Shortness of breath. What's his chief concern?
He cannot play sports.
He's scared. Came in because he was scared. So he's scared of something. You gotta figure out what he's scared of. The whole thing is he's scared of something. Okay? Past medical history is none. Takes no medication, right? So with that, what are you thinking? He's 17. I just want a differential after that. Just quick history. Just boom.
Maybe a murmur.
Do what?
Maybe a murmur.
Murmur could be.
Asthma.
Do what?
Asthma.
Asthma. Yes.
I think of pulmonary disease, like
Pulmonary. Any pulmonary.
maybe smoking and just, you know.
Do what? Pneumothorax. Absolutely. Just deconditioned. Didn't eat. Hypoglycemia. You would think, young male like that, you would think cardiomyopathy, right? You have to think about it. Because of a single episode. Anxiety. Got anxious, we'll do it. Hypotensive. Right? So a lot on there. Good. But because of the syncopal episode, palpitations, what's going to be at the highest of that you've learned in this section? Do what?
HCM.
HCM. Okay? So when Laura taught you this, what did she say? What did she say what probability to put this person at?
80%.
So 20, 50, or 80. Okay, so get a piece of paper out. I want to show you how this works in real life. She may have already done it, but. And I want you to pick what you think it is. I want you to say 20, I want you to pick 50, and I want you to pick 80. I don't care. You all should put 20 because you don't have a freaking clue right now. doesn't matter. Okay, so you start with 20, right? And you are going to find your pretest odds, right? Because this is the probability that they have this disease, right? So I think 50%, this kid, 50% has AC, hypertensive cardiomyopathy, right? So I want to find the pretest odds. So how do you do that? Do you remember? So pretest, probability, right? 1 minus the pretest. So 20% over 80%, right? And then, what's it, 0.8 over, which equals, and Lori gave you this, 0.25, 1, and 4, right? So that's our pretest odds. So this is the number you start with. Okay, so of you that thought it was 20%, take 0.25 times, what's the ratio? Oh, that's the page. What was it? 14. Okay, 14. Okay. So 0.25 times 14. So that equals what? 3.5. 3.5. What's 56. Okay? So this is now our what? Post-test odds. But that doesn't make any sense to us, right? We have to get at what percentage change. So then what do we have to do? We have to, and then do 1 plus 3.5. $78. What's this?
93.
What's this one?
98.
Okay. So, my initial patient, I did this information, I did a Valsalva on him, and I had a positive test, right? I did a Valsalva. The murmur that I heard increased when I did the Valsalva, so I ended up hearing about a murmur of whatever, a systolic murmur 3 out of 6. I did a Valsalva on them, and it increased. I really wouldn't even have to do any other physical exam if I just did that, right? If I just listened to their heart and did that. Because what do I have now? I went from 20% to 78 by doing that one procedure. Went from 50 to 93% probability that they have this disease, 80% to 98. We do this in medicine every day. I do this in medicine every day. So when I do that cardiac exam and I do that special maneuver, all those things I'm making in my head that I go, well, yeah, it's got to be this. Because you always ask, well, how did you get to that? That's how we do it. We just don't put a number to it. So you can start doing that if you get find the LR. Does that make sense? How much I increased my thought that it was this disease versus asthma, versus anxiety, versus hypotension, versus a pneumo. Unless I found distant distant lung sounds out there, right? Okay? I put this for you guys because I thought this was just a lot easier to look at. They put aortic stenosis on there by itself. Why? Why would you put aortic stenosis on this graph by itself or this chart? Do you remember what Shelley taught you about aortic stenosis?
Linked to coronary artery disease,
It is. It's true.
dissection.
True. Indeed. It's very common, and it's very deadly. Right? As it progresses, the mortality rate with aortic stenosis. So the earlier you find it, the better they do. Aortic stenosis is the big one you want to find it early. Read her slides on aortic stenosis. Okay? So ABIs are not something you have to do, but I want you to know how to do it. So, ankle, brachial, index. So, it's the difference between your leg pulses and your arm pulses. And they really should be the same. Okay? So, ankle over arm gives you your ABI. Really easy. So, you can do this by using a Doppler. It's actually a full machine. It gives you the wave and the Doppler machine, and it's in the office. Well, I don't have that, but I have a Doppler that you use to get fetal heart sounds. Works the same, very close to the same. So I can find the pulse and hear the pulse and find out the systolic pressure of that vessel very easily. So what you do is you put this on the artery in the foot and you listen to it. And then you blow up the blood pressure cuff until it disappears. And then you go up about 10 to 20. You guys did this checking blood pressure. Go up 10 to 20 more. And then you slowly let it out. And when you start to hear that sound again, that's your highest systolic measurement. Okay? And that's my ankle value. You do it bilateral because you want to check. And you do both of the foot arteries. So you do both of those. You take the highest. And then you do the brachial the same way. And you find the ratio. And obviously, one is great because they're equal. And as you go down, 0.9, 0.8, all that stuff, it's the worse it gets, the more severe it is. So I'm going to show you how to do it. There's also that you can actually just palpate it, and you get close to the same value. So some people actually don't have a Doppler in their office. But if someone's complaining of intermittent claudication, you could do this on your own by using a blood pressure cuff and palpating it, if you're good at palpating it. So, who wants to be my guinea pig? Come on. Now, they have to be laying down. They need to be supine, so both of the arteries need to be level with the heart, because that's a better look at their, yeah, we have a great table to do this. Do it. Yeah, that'd be great. They need to lay for about 10 to 20 minutes, about that. And they also shouldn't smoke beforehand.
Clear out.
But, you know why they're not supposed to smoke? What does smoking do?
Increases pressure.
It vasoconstricts. Yeah. All right, so she's gonna lay on down. We'll just do it, I'll just do one to show you. I'm so awesome that I untie your shoes. Take your shoe off. I am a foot person. They're sweating. This is gel, okay? And my blood pressure cuff, you just put it right around the ankle. Remember the width of your cuff should be about 20% greater than the diameter. That's another, remember that. You want to leave you to do it. So it doesn't really matter the artery thing lining up, it doesn't. I'm just compressing the wound. So you just make it so it's firm. Okay. So you can find, this is the bone I'm talking about, right? So you feel this and you roll lateral. And that's her pulse right there. Okay? So it's usually 2 centimeters back and down, which should be right there. Okay. So I should be able to hear. Oh, I left that there. So it just turns on. It's real easy. Well, gosh darn it.
It's a terrible football. Terrible.
Put your other foot there.
Well,
I don't think Blair has a heart.
That makes sense.
That makes a lot of sense.
I have to get a tough one. I'm sorry. I think mine.
That's good circulation.
All right, new volunteer. This is way too hard. Sorry. I can get it on mine, like, I don't know if I can feel it. I have terrible circulation. Yeah, your feet are colder than ice.
I don't want
It's really cool when you guys hear this. It's really
I think my heart's racing.
Too much caffeine again.
So we'll have their like we'll practice just and then we'll do it and then we'll do it. But they have like an actual condition. Yeah, it's so scary. Yeah, so we see it. One. Yeah, that's right.
You got great pulse. No, it's just being deeper. All right. You're even nervous. You're just like straight.
She just wanted to lay down.
She did. Kind of depressing. Go back to the I'll let you guys play with this. This is really kind of fun.
That's our pumping up the blood pressure machine.
God, I'm shaking so bad. Shelley, come hold this. Can you see my familiar tremor now? Whoa. I really have a bad familiar tremor.
A steady hand, Collins.
I know. I really have a bad tremor. Okay, here, right, it's right here.
We never did these. I don't know, but yeah.
Which, should her legs be greater than her arms, or arms be greater than her legs in a healthy person?
Then why would, then how could they be perfect being wrong?
And remember, I got a Doppler, so I'm gonna hear the very first sound. So it's not, this isn't a measure of blood pressure. Alright, so let's get. Let me get this on you.
You hear that all the time.
Because they're laying down.
Why is the pulse greater, the pressure greater in your leg?
Bigger vessels.
But you're.
No, that's when you're sitting up, that's like grabbing.
Oh, nope, because of what, wait, sorry, what did you say? Bigger vessels.
Yeah.
Bigger vessels.
Oh, you don't?
Oh, you know.
Remember, what happened, what if you have less pressure in your legs?
Terry's.
I told you, I'll have to remember that.
That's.
You have less pressure in your legs. The artery flow, there's cup of blood flow.
Wait, could somebody say that again? I didn't hear that.
You have less pressure in your legs.
I think you have like an artery occlusion.
A what?
An artery occlusion.
Stop.
Artery occlusion. Because it's not getting to your legs.
Oh, they haven't had it
It's
yet.
not getting to your legs.
Oh,
I lectured.
oh, my bad.
Oh, y'all remember that?
Oh. How do you know when to stop the pressure? I mean, what do you hear that you stop the blood pressure at?
She's stretching. I'm hungry. I'm eating.
Okay.
Tomorrow. Yeah.
It was still, your pressure's still.
Huh? That's probably won't come up till Wednesday.
Yeah, I think
It has to do with
Did you hear it? Yeah. It's a big difference, because it's,
Can you just clarify?
that was 132.
If you are laying down and you do that and you have less pressure in your legs, that's,
No. That's not. I just was saying, if you have blood pressure,
yeah.
this has nothing to do with blood pressure, right? This has nothing to do with blood pressure. Blood pressure readings.
No, I know.
I said, if you have less blood pressure in your legs versus your arms, you better go look that up, because that is a complete intense question. And I already lectured on that. Blood pressure, systolic, diastolic. But this right now is a value.
Mhm.
And I got what did I say, 138?
Mhm.
Systolic over 132, which is what? You don't even have to tell me exactly. It's greater than 1. It's like 1.06, but it's greater than 1, so she has great vessels.
But if it were less in her legs than in her arms, that could predict.
If her pulse was less in her, that systolic number,
Yeah.
don't think of it as systolic, but this is kind of what I want you to think. If that number is less, Here, let's just do it easy. Let's just say it's 90. 90.
My legs.
And it's 120. What you gonna get there? Not 1. It's gonna be less than 1, right? Right? If I get, like we got, a bigger number, so I got 138, I was like 132. I got greater than 1, so we know that she's got great blood flow. The index is greater than 1. 1's normal. Anything a little bit greater than 1 is great. There's no occlusion in the peripheral arteries. And the first things that you tend to occlude are the very farthest away, which is these guys.
So if it's less, we can predict that there could be an occlusion or an
It's
atherosclerosis or something.
very, very diagnostic.
Okay.
In fact, that's what they do. And then they go in and review.
So if you're testing both legs, why does it specify to take the higher number instead of the lower one? Because wouldn't you want to go with the lower one and then you could know if there's something going on in that particular leg?
I don't know, that's just what they say.
Or is this only specifically for overall peripheral arterial disease for both?
It's an estimate of, I mean, it's you're predicting how at risk they are for a peripheral vascular disease or artery disease. But I
Because
don't know why they say that. I have to look that up for you.
well, but the thing says go with the higher, like the slide before this says go with the higher number for the two legs. But if you have a difference between the two legs, couldn't that be saying, hey, you have peripheral disease in one and not the other?
Absolutely.
If you look at the slide, though, that's not what it says. The one before, unless I read it wrong.
Yeah, you can do right and left, but wait, if someone, it's usually bilateral. If I have an acute, I mean, if I just have one leg, that's a big, it's an acute situation. Usually what you have is it's a peripheral artery disease, and it's an idea of what's going on, right? Acute is totally different. We have a pale, white pain, it's a big deal, pulseless. But this is an idea of someone's overall peripheral arterial disease.
So could this also be used for like deep vein thrombosis? No.
But I will tell you, you can actually, that's not exactly true, but you don't use this index. You can actually do, you can do a Doppler, and what you get is you can listen to the Doppler, and as you let go of that, you'll hear regurg. So you can use this test to listen for a lot of regurg. So if you have an occluded venous system, you'll get regurg. Oh. But there's you don't know that. And it's not diagnostic or anything, but if you read about it, you can see it.
Say a patient came in walking or running, wouldn't the pressure be high then? Wouldn't it be extremely
Yeah.
high?
Yeah, that's why you have them laid for 20 minutes. The recommendation is
20
just,
minutes.
so they become their norm. Their norm.
And is there a certain requirement if the pressure is really high that something else is going on with your
It's not a measure of blood pressure.